So welcome to this part 2 of the application of artificial intelligence for clinical cancer research. Now we will see the application for the clinical trial itself concerning patients, and we'll see what are the improvements we can expect from AI. What are the problematics for patient enrollment in clinical trials? In fact, we see that for patients with cancer, affected with cancer, the recruitment to clinical trials is really low. For pediatric cancers, this is not really the case because we see that worldwide there is almost 60% of the patients that are referred to a clinical trial. For adult patients, this is clearly different. Worldwide, it's less than 5% of the patients that are referred to a clinical trial. And in France, we can estimate that it is around 1.5 or even 2%. And we know that the target, the objective, mostly shared across states for recruitment of patients in clinical trials are more than 10% at least. So we are well below this rate, and we'll see how we could increase this rate. Another factor, one of the factors that explains this low rate is the frontiers between states and the problem of access to clinical trials. And I want to show you the local examples of our hospital, Centre Léon Bérard, in France, in the Lyon area, together with HUG, which stands for Hôpital Universitaire of Genève, which is in the border, very close to the border in the Swiss side. And we have analyzed the access of patients across this border to clinical trials between these 2 years, between 2021 and 2023. So when we zoom in, you see here in blue the patients that go from a department to the HUG in Switzerland. And in gray, the numbers refer to the patients that come from a department and go to the CLB in France. And we see that there is a clear drop because of the frontier. As you see here, that there are only 7 patients from the Haute-Savoie that goes to HUG. However, it's very close, and it's closer than CLB. And the other way around, in Geneva, only 4 patients come to CLB, and most of the patients stays in their country for clinical trials. However, clinical trials can be different between the sites, and by increasing the access to clinical trial, it can increase the possibility for a patient to access new compounds and various compounds for the care of their cancer. So less than 5% of patients referred to clinical trials are also due to many other factors, such as the information of the patients and the physicians in the country or away from the site about the clinical trials that are accessible mostly. There are other factors that we will see afterwards. Another attrition rate that is specific for early phase clinical trials is the early end of participation of a patient in an early phase clinical trial. Those early steps in clinical trials are represented by the screening phase and the DLT phase. Screening phase is the phase between the consent of a patient to participate and the start of the compound. There are mostly many exams to perform during this period, such as, for example, brain or whole body CT scan or biological exams. And early stopping at this stage is almost 15%, meaning that this patient during this period don't fulfill a criteria that we will see afterwards. Then during the DLT period, which stands for dose-limiting toxicity, this refers to the period, the first 28 days, mostly, of a patient taking the medication, the compound, during an early phase clinical trial. And we know that during this phase, there are also 15% of the patients that may early stop the clinical trial, not because of the compound, of course, but because of other reasons. And we see that when we add and we do a mean of the number of patients that early stop a clinical trials, it's 40%. And at the end, it's only 60% of the patients that could continue the clinical trials and hopefully benefit from taking the compound in this clinical trial. This attrition rate affects many steps of the clinical trial and the care pathway of the patients. Most of the patients we will see maybe would not benefit from a clinical trial if they early stop the clinical trial. They may benefit from other therapies, palliative therapies, or other type of care, other approach than a clinical trial that is often very demanding. And it also slow down the advancement of the clinical trial, because those patients that stop early before the end of the DLT period cannot be evaluated in the clinical trial. So we have to recruit another patient in order to have the endpoint, which is what happened during the DLT period. So it slows down all the process of the clinical trial. So improving those two steps could increase the path of a clinical trial and the number of compounds in clinical trials. So we have seen that there may have two objectives to increase and improve the access to trials. First objective, as you see in the slide, is bring patients to trial. So increase the information, increase the matching of patient to trial, and improve the access across borders. This is something that we are working out with the project Trial Match 2 that I will present to you just after. The other objective is bring trials to patients. Of course, if a patient cannot travel, and it's often the case, having more trials closer to their location could increase their access to trials. And this is one of the objectives we address in PCM4U and Primrose, which have for objective to diffuse the clinical trials in different countries. So how you can increase the access of patients to trial by improving the information. So there are the two applications represented here. First is the trial matching tools that could increase the information and the access of patients to trials. And then there are tools for eligibility predictions that could increase the number of patients that stay long enough in the trials. So first, trial matching tools is a new set of tools that are actively under development. As you see, there are plenty of groups or even startups and companies that invest and develop methodologies to do that, either in France or worldwide. The main idea under trial matching is that you have patient characteristics, so their disease, their age, the number of and type of treatment lines, the site of the metastasis, for example, and you see if it matches the selection criteria of the trials. Selection criteria are mostly used to select the patients for a compound, and we know nowadays that many compounds are targeted to alteration, molecular alteration of cancer. So this is a selection criteria often seen. Other type of criteria are, for example, type of cancer, number of treatment line, etc. So we can, by these two data, patient data and clinical trial selection criteria data, do an automatic matching of which patients could fit to which clinical trials. And there are different maturity of those tools that we'll see. So, first generation of the trial matching tool were in fact mostly based on manual creation. So we know that manual curation, as you see in the table, don't require a platform, is quite easy to set up, but is very time consuming, and a human resource is very needed for manual curations. So we go to a second generation of such tools, which of course is semi-automatic search of trials for patients. This mostly it's mostly stored on the cloud. Of course, there are automatic updates of the clinical trials and their selection criteria because it can change very fast. And the clinical variables are the difficult part because there are few tools in this generation that provide structured variables for the patients. So this is quite a recent application, but there are already a third generation of trial matching tools. And here, this is mostly automatic. It could use the report of the patient, so electronic health records. It could use the text about the clinical trial criteria and do automatic matching, and I will show you an example of that. So semi-automatic trial matching mostly look like this, where a patient or physician can put the information of the cancer of the patient, the histology, the mutations, and then do the search from these criteria and come with a list of clinical trials that could fit to the patient. The third generation with fully automatic trial matching is represented here. It's not a published work, but André Freitas gently provide us with the preliminary results of his work with this team. So you see here that there is a description of the patient at the top of the figure, which is kind of a classical way to describe a patient in a clinical report. And you see at the bottom of the slide the inclusion criteria for kind of classical clinical trials. And you see that inclusion criteria in fact lists different characteristics. So the first one is a patient with an history of chemo within the last 24 months. The age should be more than 60 years old. The patient should have a cancer HER2 positive, etc., etc. And here with the colors, you see what the tool detected as related between the clinical trials criteria and the clinical variables. So you can see, for example, that the tool detected that the trial is for HER2 positive, and it matched in the clinical variables RBB2 breast cancer, which is a synonym and which indeed fit to the selection criteria. So how does it work? It's quite a complex process, but I want just to give it an intuition to you. So André with his team have a database of language models, and for each task they ask for the model, they choose a language model and a specific prompt, a specific question for the model. Then it has a step of, as you see, LLM, which stands for large language model, which will go deeper into the exploration of the text. And what the team does is that it does automatically prompting, so questions to the model to check for the information in the text. But of course, with this description, you can ask yourself how the model could understand the synonyms between the two words, for the example, we just see about RBB2 and HER2 positive cancer. So this is under the box. In fact, there are multiple steps of questioning, and André called that multi-hop reasoning, which in fact is a sophisticated way to query a model to deduce some information from the texts. For example, with our RBB2 versus HER2 positive, the prompting is it an alias? And if yes, indeed, it can be deduced as a synonyms. But you see here in the slides that there are many different tasks to go across to indeed have this matching automatically. And so the team have built up a series of prompting and querying of the model to do this automatic matching. They come out with an application interface that is very simple, as you see here, and that hopefully we can access to soon. So that was the example about trial matching tools, and then I want to give you a glimpse into the eligibility prediction tools available to date. So phase 1 selection criteria, as you've seen, in general are listed in a clinical trial protocol, and physicians or now tools are checking if the patient fulfill all the criteria. We also use other tools to predict if a patient will stay at least 1 or 2 months in the clinical trials. And these are scores, mostly prognostic scores, to evaluate the prognostic of the patient and indirectly if the patient will stay and how long in the trial, independently of the compound of the trial. So you see that there are a lot of it. The one that we use mostly is the RMH, which stands for Royal Marsden Hospital score, and is based on, for example, albumin level, LDH level, and the number of metastatic sites. And you see that most of the scores that are quite similar, in fact, have a concordance index. So concordance index is a performance score between 0.6 and 0.9 for some, but it's mostly around 0.770, which is quite good, in fact, but maybe not so good to go to a very clinical application with a good confidence. So there are new tools that you see here, like RoPro or Camembert, which are tools based on machine learning techniques that took a lot more of variables. For example, RoPro take as input 24 clinical variables, structured variables, and Camembert took only the consultation reports of the patient to predict the prognostic of the patients. And you see that either it increases the performance or it facilitates the application of the prognostic score. But could we be more specific to clinical trials? Of course, yes. So we could train a model to use the patient's data and to predict if the patient will stay or not in the clinical trials. And that's something we have tested. And by training the model and evaluating it on the independent cohorts, we saw that the AUC under the ROC curve was quite high, 0.88, and so it was a very encouraging results. And in practice, how it impacts the early stopping of the patients. So applying this model could decrease this early stopping rate from 40% down to 13%. And so in practice, it could really lead to better selecting the patient for early phase clinical trials. So if we want to wrap up all the presentation, we could envision, and I hope this would be the case, but that's only personal predictions. We could envision that more than 20% of patients could be referred to clinical trials thanks to trial matching tools. We could envision that better compounds will go to clinical trials and early phase clinical trials. And when a patient is selected for clinical trials, there would be more than 80% of patients that would stay long enough in the clinical trials to hopefully benefit from the treatment, and that's with eligibility prediction tools. So my conclusion for the second part is that NLP, natural language processing, can help proposing more clinical trials to more patients. It can also improve the recruitment of the patient and accelerate the study timelines. But of course, all those technologies that I've shown to you should be carefully evaluated before they are applied in the clinics, and that mostly goes through proper clinical trials or clinical evaluation of those technologies. And with that, I thank you a lot for your attention, and we'll see in the next podcast what are the applications and what are the prospects to better bring trials to patients within the PCM4U and Primrose initiatives. Thanks a lot.